All right. Hi, everyone, and welcome to today's webinar. You have joined a webinar entitled Proposed Limits on Public Health Authority, Dangers for Public Health. We're excited to bring this information to you. This information is really inspired by a report that's been created by the Network for Public Health Law, NACCHO, and Johns Hopkins University to help to illustrate some of the issues or some of the concerns related to limitations on public health authority. We're excited to bring you the information today that will provide some further context onto this issue and hopefully be useful to you all as you consider this issue in your day-to-day lives. And so just really quickly, some logistical topics just to go over. If you have questions, please submit them through the Q&A box on the Zoom platform. There is a Q&A function. Please utilize that one versus the chat function. The recording for this webinar will be sent to registered attendees. And so even if you have colleagues who are not in attendance, they will still receive a link to the recording of this webinar. And in addition, on NACCHO University, which we have the website listed below on the screen, the recording and slides will be posted for future use and reference. And so again, this webinar is really rooted from the report that's been created regarding proposed limits on public health authority, dangers for public health. Further information on this report will be provided in the messaging that goes out following this webinar, so you'll be able to gain access to the file related to the report. And you could also receive information on this report on either the Network for Public Health Law's website or on NACCHO's website under press releases. And once you receive the slides, you'll be able to use the hyperlinks in the presentation to access much of the information that's going to be presented. And so really quickly, topics of discussion for today. Of course, we're starting with an overview of the topic and the context in which this report has been created. We're then going to follow that up with a discussion on laws impacting public health authorities and their potential impacts on public health and on our communities. We're going to also have a discussion on a real world example of challenges to public health authority. And then we're going to follow that up with a Q&A portion during the webinar. Listed here are our speakers for today. First, myself, my name is Jeff Mongulu. I am the Director of Public Health Law over at the National Association of County and City Health Officials, otherwise known as NACCHO. Lori Tremmel-Freeman, the CEO of NACCHO, is going to be following up this introductory portion of the webinar. She'll be followed by Jill Krieger, Director of the Network for Public Health Law, Northern Region. And then following Jill will be Joe Mazzola and Joe Durham. Joe Mazzola is a health commissioner for Franklin County Public Health in Ohio, and Joe Durham is an attorney who is legal counsel for Franklin County and the Association of Ohio Health Commissioners. And with that, I'm going to hand over the presentation to Lori.
Thanks so much, Jeff, and good afternoon, everybody. It's great to be with you here today. I so appreciate the opportunity to visit with you briefly to talk about some of the alarming trends that we in public health authority that we have seen taking place across the country. Talk a little bit about the genesis of this project and touch on what we are learning before we hear from our primary speakers. It's been a truly exceptional time for all of you working in public health. Today, our local health departments and our leadership have truly been leading on the front lines of the pandemic response as community health strategists. Yet at the same time, many of you have been under attack, quite frankly, whether it's the politics of this pandemic, the underfunding, the stressors of being overworked. We wanted to recognize this trending on public health authority early enough to elevate attention to it and to fight back with it. Next slide. So we have been learning a lot during the course of the pandemic about the duress that our local health officials and local health departments are under, and nobody knows this more than you all know this, but across the country in red states and blue states, large metropolitan areas to rural communities. Public health officials and the staff that serve those departments have been physically threatened, politically scapegoated, and quite honestly, too many have lost their jobs for trying to protect and defend the health of their community and responding to this pandemic. During the pandemic, extremists and other activists who have opposed hard measures to halt the pandemic, including stay-at-home orders, mask mandates, contact tracing efforts, vaccine, have really sought to intimidate health officials to change these orders. We saw a continuing flurry, it continues today, of health officials resigning, taking early retirements, being fired. In that number, sadly, is now up to over 250 departures across the country. We know you're tired fighting this pandemic. You're on those front lines working day in and day out with little relief and even less recognition for the work that you're doing. And on top of all of that, we've seen a politicization of public health that we've, quite honestly never seen before in our lifetimes. Next slide, please. In recent months, at least 15 state legislatures have passed laws or are considering measures that limit the legal authority of public health agencies to protect the public from illness and injury and death. Other states may consider this type of legislation in the future. Some disaster was avoided during recent legislative sessions, but it's foreseeable that these legislative attempts could return in the future. And this report really takes a look and finds that dissatisfaction, anger at perceived overreaches by governors and public health officials in response to the pandemic is really spurring this activity, this onslaught of legislative activity to limit the authority of public health officials. And I'm sure we'll get into this in more detail, but dangerous territory that we're encroaching on here, because once that public health authority is lessened or changed, because of one public health emergency like a pandemic, the reasonable measures that we take place to mitigate disease in the future, like mask wearing and social distancing and quarantine, if limits are imposed that prevent our public health officials from executing those important mitigation efforts in the future, it really comes down to an inability to protect the life of the citizens that you all serve, and poses some serious risks, public health risks to the communities that you so ably serve. So I don't want to take much more time on the last slide. I just want to recognize that this work emerged after, next slide please, after we started to hear and see for ourselves from local health departments across the country that this type of legislation was being introduced. We also saw some early efforts to even change the governance structure of health departments so that authority might be taken away from them in other ways as well. And we approached the National Network for Public Health Law, who has been a wonderful partner to NACCHO during this pandemic. And they quickly said, yes, what can we do to help? How can we help? So with the network, who is supported largely by the Robert Wood Johnson Foundation, along with some partners that we have been working on the threats and intimidation and firings and resignation piece from Johns Hopkins, including Dr. Josh Sharpstein, Beth Resnick, and some real experts in the field, Leslie Zellers, Wendy Parnett, Lindsay Wiley, and other partners, Change Lab Solutions, Local Solutions Support Center. All of these folks stepped up very rapidly and helped us to put together the report that you'll hear about today. We don't see this as the end of the subject. This is the beginning of the tracking of this, and we really want to continue to work to avert further harms to your authority on the ground. So that's all that I have. I really thank you for participating in today's webinar, and I hope you'll find much value from it. Back to you, Jeff.
Thank you, Lori. It's our next speaker, Jill Krieger with the Network for Public Health Law. Jill?
Thank you, Jeff. Yes, I'm the director of the Northern Region of the Network for Public Health Law, and it's a pleasure. It's a pleasure to be here with all of you on the webinar if the occasion for the webinar is not a pleasure. And do want to thank NACCHO and all the other partners on behalf of myself and all of my network colleagues, including our national director, Donna Levin. So I'll be focusing on kind of the meat of, part of the meat of the report, which is looking at the actual state legislation that has been proposed or in many cases passed, enacted to limit public health authority. Next slide, please. As Lori mentioned, part of what's particularly challenging about this circumstance is that you all are under a triple threat: threats to public health, threats to yourselves as public health officials, and threats to public health authority. That's a lot. Next slide, please. So most of you will be pretty familiar with public health law as, you know, a core domain and activity under the essential public health services. This is kind of the classic definition of public health law, which is conceptualized as the struggle to balance government powers and duties with individual liberties. And we've certainly seen that in the course of the COVID-19 pandemic. But we're really going to focus on the top half of the balance in this presentation. Next slide, please. Because the question that we're asking with much of this legislation, or trying to answer with, that the proponents are trying to answer with much of this legislation, is which government, what powers and duties? Next slide, please. So in the report, we reviewed 14 bills, at least 14 bills from 14 states. Now, this isn't meant to be a comprehensive review of every bill that was introduced that pertained to public health authority and emergency powers in legislative sessions in 2020 and 2021. It's more a survey of examples to illustrate some of the trends. And these trends are laid out in the report. The categories of the types of legislation that are causing concern because they diminish the flexibility, the speed, the authority, the authoritativeness with which public health departments are able to speak at the state and local level, primarily in the context of this report. Certainly there's a lot that one could say about federal authority and tribal authority, but this report is focused on state and local authority. So what I'll do is discuss an example of one example from each of these 5 categories where there's a shift in power. It's either reallocated from one level of government or from one branch of government. So it's reallocated from the locals to the states, or reallocated from local or state executive branch to the legislative branch at the local or state level, or in some cases, there's simply an outright prohibition on certain types of state or local public health orders. Next slide, please. So the report does have more than one example of each of these categories of laws, and you know, represented by the colors that are used in the report itself to demarcate. Now, some states you'll see are up here multiple times. In fact, Kansas and Ohio, the bills that were enacted in Kansas and Ohio actually hit 4 out of the 5 categories, and the bill enacted in Florida hits 3 out of the 5 categories. Now, we didn't necessarily know this even 5 or 6 weeks ago when we were just starting on this report. But we identified the bills that were of interest and concern due to their substance, as well as we did try to take into account from what we could gather from partners on the ground in terms of their propensity to pass. In any case, next slide, please. So the yellow category are those pieces of legislation which would move authority from the local health department level to another local entity. So for example, a county board, a city council, typically an elected or legislative body, an elected legislative body. Now in Montana, 2 of these bills passed. And as you saw in the previous slide, I didn't note in the previous slide, the states which were named in bold are those where the bills had been enacted at the date of publication of the report. In any case, Montana passed 2 bills that would reassign authority that had resided with local boards of health to local governing bodies, typically county boards or city councils. So this bill, these 2 bills rather, empower the local governing body to rescind local Board of Health emergency orders, redefines isolation and quarantine such that isolation and quarantine may not occur while test results are pending or during the course of an investigation before conclusions have been drawn about whether someone has an illness or has been exposed to it. This is highly problematic, of course, in terms of the importance of quick action to prevent the spread of an infectious disease, even if that action may be prophylactic in the case of restricting the movement of 1 or more individuals until it can be determined whether there is a risk that they would spread the disease to others. In addition, the bills would bar local ordinances that would close businesses except in limited circumstances. These bills have been enacted, and there are tremendous implications to these bills. They increase the risk of spread of disease. The fact that there were 2 bills that passed that amend the same provisions of Montana law has created confusion as to, are these both in effect? Are these both operative? If not, is it the later enacted that's operative? Well, what do we do? Furthermore, the bill indicates an intention, the first bill, House Bill 121, indicates an intention only to apply to emergency orders, but then there's also confusion about whether it also applies to more day-to-day environmental health and sanitation matters. Next slide, please. So the second category of bill would reallocate authority from local health departments to state health departments or the state legislature. So our example here is from the state of Indiana. This bill would essentially prevent local health officers from imposing emergency disease prevention measures on individuals and businesses if they would be more stringent than those issued by the governor. Now there is something of an exception in that the local governing body can approve a health order proposed by a local health officer, even if those provisions go beyond state requirements during an emergency. But it requires an extra step then with the local governing body approval that was not previously required. The status of this bill, it was enacted over the governor's veto. Implications here, again, it delays action, it limits flexibility. Oops, sorry, excuse me, I'm having a little, it limits flexibility and the ability to tailor orders to local needs and data, which is critical for an effective public health response. Next slide, please. Now, in some ways, one of the types of bills that's gotten, I think, a lot of attention in the media is bills that would prohibit certain state or local public health orders. One of the kind of poster child bills is from North Dakota, which would prevent a statewide elected official, such as the governor or a state health officer, which does, prevent those officials from requiring any individual in the state to wear a face mask, a face shield, or other type of face covering. And this was enacted over the governor's veto. Now, interestingly, though, there's a sense in which, because of the narrowness of the focus of the bill, there's some sense that perhaps the two preceding categories might be more troubling. And also, interestingly, in North Dakota, a provision in the bill which would have also stripped this authority from local health officers and local elected officials was not enacted, so that there's some retained authority at the local level. The implication of this is you're going to have a piecemeal response. It's really hard to have a coordinated response, which is really important in the case of infectious disease, particularly in one where contact tracing capacity has been overwhelmed, as it was with COVID-19. Next slide, please. Kansas House Bill 2016 is an example of the category where authority is shifted from the state health department to the governor or the state legislature. So the Kansas bill does a number of other things as well, but for this purpose, we're focusing on this aspect of the bill, which removes the governor's ability to close businesses during a public health emergency and requires legislative approval in order to extend a governor's emergency order. This is another bill that has been enacted. So again, we have here we have a shifting. The implication is that we shift the responsibility from state and local health departments, people with public health experience, expertise, and training, to elected officials who do not have that experience, expertise, and training. So we'll have necessarily a more difficult time making these judgment calls, or may need more time simply to get up to speed and to deliberate as there are more people, which can impair preparedness, the ability to effectively respond to a disaster, and may also have an adverse effect on routine public health operations. Next slide, please. Okay, the fifth and final category of bills that we reviewed in the report is a category of bill that transfers authority from the state executive, whether that be the governor or another official, to the state legislature. The Florida bill, and again, this bill has multiple parts, but we're looking at this aspect of the bill. This bill authorizes the legislature to terminate orders issued by the governor under a state of emergency. It prevents a business or government entity, so it does affect the state executive's power, from requiring proof of COVID-19 vaccination to access services. Now, there have been bills proposed in other states that address this same concern, and not all of them are limited to proof of COVID-19 vaccination. Some are broader still. In any case, the implications of this bill is that we have allowed the legislature to essentially veto orders issued under a declared emergency. And some of those other provisions that we're not discussing in detail here would similarly impede the ability of local governments to respond to public health emergencies. So overall, we simply have a set of legislative proposals and enacted laws that really do pose a threat to public health. Next slide, please. So the report has 4 conclusions, and Lori alluded to some of these, but essentially our conclusion on behalf of the network, NACCHO, and in consultation with many partners on the front lines, as well as legal experts, is that these bills and laws block reasonable public health measures, and it poses an immediate threat to life and health. Some legislatures meet a few months out of the year or out of every 2 years. So to reallocate authority from local health officials who work year-round and have staffs working year-round and coordinate with partners for emergency response, to reallocate that authority to governmental bodies that aren't in session much of the year, really poses a risk when infectious disease can spread so rapidly. In any case, there are certainly foreseeable and unforeseen serious risks to life and health by sidelining the experts in the response. We also conclude that much of this legislation violates the constitutional separation of powers and undermines effective government response. Finally, we conclude that if adopted, these bills would make it harder to advance health equity during a pandemic where we've seen disproportionate impacts upon communities of color, including African American, Latino and Latina, and indigenous populations, as well as hate crimes, discrimination, and mental health impacts on Asian American populations. But all of the ability of public health to address those concerns is impeded by some of this legislation. Next slide, please. So I'm not so good at sports metaphors. We talk a lot about how striking it is that after one of the greatest threats to public health in over a century, we're playing defense in terms of the legal response, and we ought to be playing offense to strengthen our public health law response. But children's literature is more my métier, and in honor of Eric Carle, who recently passed, I think some of these state legislatures are going to end up with a case of indigestion when they see the impacts of some of these bills that have been enacted. So we do need to think about how the legal response, and as noted, the report concludes that some of these laws may in fact be unconstitutional. So we may have legal tools in our tool belts to challenge these laws and prevent them from being implemented. And we need to turn our attention to strategies to build up our public health infrastructure and workforce. Next slide, please. Here's some additional resources that you consult. I can commend those to you after you're able to review the slides after the webinar. Next slide, please. And then I'm certainly happy to answer questions or refer you to colleagues throughout the country who may be more familiar with the laws in your state. Thanks again for having me, and I'll hand things back to Jeff.
Thank you so much, Jill. Great presentation, really appreciate it. All right, our next presentation is from Franklin County, Ohio. I'm gonna hand it off to Joe Mazzola to start us off.
Great, thank you, Jeff. Good afternoon, everyone. It's good to be with all of you. And I wish it was perhaps under a better topic, but I really appreciate the network's report, the partnership with NACCHO. This is a very, very critical topic for local public health and all of public health. And so really appreciate the opportunity to be a part of today's discussion. Next slide, please. So I'm going to set the stage for what is happening or what has transpired here in Ohio, and then I'm going to turn the presentation over to Joe Durham to talk about one bill in particular from the legal aspect, and hopefully will give everyone an opportunity to really get a better sense as to how Ohio's experience has certainly played out here with respect to some of these particular bills and pieces of legislation. Next slide, please. Before I go on, I want to acknowledge NACCHO again for the invitation today. Also want to acknowledge Beth Bickford, our Executive Director of the Association of Ohio Health Commissioners. Proud to say I am the current president of AOHC, and this presentation was put together mostly by Beth in cooperation with Aaron Ackerman, who is the president of Ackerman Consulting, who is the AOHC lobbyist for us, and really has been instrumental in coordinating our overall advocacy efforts here in the state of Ohio. Next slide, please. So a little bit about kind of where we are in Ohio with some of our politics. So Governor Mike Dewine, who has in his third year here in his first term of Republican, and our House and Senate both with Republican majorities. Governor Dewine has been very much a strong champion for public health, but you'll see here that at times has been challenged, if you will, by his party here in Ohio. We do have a full-time legislature, and we do have a new session with new legislative leadership as of the beginning of this year. So the dynamics of the legislative environment certainly are interesting, and that just gives you a little bit of sense as to what that looks like here in the state of Ohio. Next slide, please. So Ohio's public health system is, like many states, a decentralized public health system. We, of course, with our state health department, we have 113 local health departments across the state of Ohio. We here in Franklin County are one of 2 health departments, Franklin County Public Health, and then the city of Columbus has a health department as well. But we have a very robust public health system here in the state, and we, of course, work very closely with our state health department on any number of issues, rules, program administration, and other topics. So our public health system really is what we think is in a very strong place. But of course, with these types of conversations with respect to some of the laws that are being considered, really jeopardizes that infrastructure. Next slide, please. So again, a little bit more about Franklin County Public Health. So we are, again, one of 2 health departments in Franklin County. For those not familiar, Columbus, Ohio is the capital, obviously. So ours is a general health district. We provide public health services to 41 local townships, villages, and cities in and around Franklin County. Our jurisdiction is about 480,000 residents, and we're governed by a 5-member board of health. Next slide, please. So now a little bit about where we are with the landscape of some of the bills that we have had to respond to here in Ohio. You can see here just a number of different bills that have been introduced over the last year that really speak to the topic that we're talking about here today. We have House Bill 90, which really speaks to the oversight of the governor's executive orders. House Bill 127, which is one of several bills that really speaks to the business community. We've heard, that the employer business community and some of the quote unquote fairness with respect to how businesses have to comply with public health orders. So there have been several House bills and Senate bills with respect to that. And then also several bills which relate to, of course, limiting public health orders, both at the state and the local level. I do want to point out, in addition to that, the more general bills with respect to public health authorities, we have seen an increase in other types of bills prohibiting things like mandatory vaccinations. And so, I think that this really is, again, a topic that can be certainly more broad, but then also more specific to certain public health issues like vaccinations. And then I want to sort of center in on Senate Bill 311 and Senate Bill 22, which really is the sort of the bill that we are having to kind of work through right now with respect to public health orders. Next slide, please. So Senate Bill 311, this was in the last legislative session, and you can see the timeline of how the bill moved through the legislature last year. It was introduced in May, passed out of the House and the Senate. It was vetoed by the governor, and that's when I spoke earlier about how the Governor Dewine and the state legislature have not seen eye to eye on this issue. But then it sort of ran out of time in the legislative session. And so what we heard a lot with Senate Bill 311 was it's all about legislative oversight, and we've heard that a lot during that debate. So, but as the session ran out in 2020, we knew that this bill was going to resurface in the next General Assembly. Next slide, please. So now we have Senate Bill 22, which is basically kind of a new version of Senate Bill 311. Again, you can see the time frame here. It was introduced right away in January, passed out of the Senate and the House, and then the governor again vetoed Senate Bill 22, again being consistent with his philosophy on these types of pieces of legislation. But again, the House and the Senate did override his veto in March of this year, and now we are having to prepare for potentially for implementation of the bill. And I think Joe Durham will speak to those specifics. Next slide, please. So Senate Bill 22, just to kind of give a little bit of background on the advocacy efforts here. There was proponent testimony, proponent support, but there was a obviously a very strong opponent presence as well. AOHC, our state health department and governor, as I mentioned, our state medical associations, many individual boards of health took advocacy efforts, as well as pediatric physician groups and individuals who are concerned about public health as well. So we put up a very strong advocacy effort to oppose Senate Bill 22, but unfortunately it did obviously pass and has now been overridden by the legislature. Next slide, please. Again, the rationale. So these are some of the things we hear a lot about, the balance of power. Healthy people should not be arrested. It's important that we provide input to ODH on specific orders. I mean, those are the kinds of things that we, of course, hear from members of our legislature and, of course, members of the community who support these types of bills. And certainly, as we heard earlier from Jill, the impact on local public health is certainly significant and very troubling. It's a lack of understanding of what we do. It's a lack of knowledge about, the expertise of public health. And it's really about an inability to distinguish between state health orders and local public health orders. And I want to just call attention to the fact that in Senate Bill 22, the bill really started off focused on state public health orders, but then local public health orders were added towards the end of the conversation. And so I think that's why we really have to distinguish again between state and local public health orders and the relationships between those two. But for us, this is a very, very concerning piece of legislation as we think about, what could be ahead for public health here in Ohio. Next slide, please. So these are sort of the larger areas with respect to Senate Bill 22, and I'm going to turn the call over to Joe Durham to talk about, again, the legal implications and the more specifics of this particular legislation, because this is, I think, a really good example of what could happen across the country. Unfortunately, it is happening here in Ohio, but I'll let Joe talk a little bit more specifically about what this means for us here locally.
All right, good afternoon, and thank you, Joe, and Jill and Lori and Jeff for this opportunity. Somebody confirm that you can see my screen?
Yes, we can, Joe.
Okay, great, thank you. I was telling Jeff earlier, I think it's been at least 5 years since I participated in the public health law work group with Jeff and NACCHO. And it was with that work group where we were addressing local public health authorities and social distancing more than a decade ago, which really at the time I thought was more of an academic exercise, or at least I guess I hope it was. And so, let me go here. Not allowing me to move, that could be a problem. There you go. So, a little more than a year ago, we were addressing the enforcement of isolation and quarantine orders, establishing quarantine guards, the idea that some of these orders were being challenged on their constitutionality. We were enforcing through the Franklin County Public Health an amended stay-at-home order issued by the state of Ohio. And we were seeing the implementation of almost every social distancing measure that I had studied with the work group. Fast forward a year later, as Joe introduced, Senate Bill 22, and the legislator passed it, overriding the governor's veto, and they revised the laws in Ohio that significantly impact the state and local public health authorities. For local health jurisdictions and the state health department in Ohio, these new or revised laws now define isolation and quarantine to require a medical diagnosis for both isolation and quarantine. And it's unclear, but doubtful that a lab report meets this definition. But new legislation clearly limits the local health department's authority to isolate and quarantine under their existing authorities. So if the legislators' intent wasn't clear in redefining isolation and quarantine to require a medical diagnosis, they reinforced it by adopting a new section which specifically limits when a local health district can issue an order only to those individuals with the medical diagnosis. So in 2020, some of our local health districts in Ohio, based upon the then existing statutory authorities, had issued orders closing schools. This led to legal challenges based in state and federal courts, where courts addressed the constitutionality of the orders. Then Senate Bill 22 came back and further limited the local health district's authority to regulate schools, specifically prohibiting district-wide orders, and limits such orders to specific schools with verified positive cases, that's plural, of the disease. Similarly, this section of the revised code that was adopted under Senate Bill 22 indicates that under Chapter 3707, the Board of Health may only issue orders to specific persons. So while a local health district can still issue orders to a specific individual or a specific business, and while they still have, at least for the time being, on the books, some authorities to regulate during a pandemic, I wanted to give some real world examples of how Senate Bill 22 has implicated the public health authority in Ohio. Franklin County Public Health in July of 2020 issued a mask order mandating facial coverings in the health district. That was adopted based upon then existing statutory law and a 2002 Ohio Supreme Court case in which the Supreme Court of Ohio stated that local boards of health are better situated than the General Assembly to protect the public health. Faced with this mask order that was adopted and intended for the general public, in light of Senate Bill 22, Franklin County Public Health rescinded the mask order 2 weeks ago, or it would be invalid on the effective date of this legislation, which I believe is June 22nd. So there are two chapters regulating, giving the authorities for local health districts in Ohio, Chapter 3707 and 3709. And the legislators didn't stop with 3707, which is really about the general authorities of local health districts during public health emergencies. They adopted new legislation, 3709-2112, or 212, says that orders of the Board of Health can only be issued to those that have medical diagnosis, had direct contact with those with medical diagnosis, or that have a documented incident in the building of the disease that is subject to the order or regulation. Now, the board had issued an order to a business that had consistently failed to comply with the board's local mask order and the state of Ohio's mask order. Again, because there wasn't a documented incident of the disease, that order was recently rescinded as well. Local health district has the authority to adopt regulations under the current statute for the public health, the prevention and suppression of disease, and the prevention, abatement, and suppression of nuisance. All of the other orders that we have addressed specifically related to the regulations that were for the public health or the prevention and restriction of disease. However, this new provision in Chapter 3709 is not specific to those and may impact the Board of Health's ability to regulate nuisances because it isn't specific to just the prevention of restriction of disease. And so we are currently looking at all of the regulations to determine whether or not they have to be rescinded, if they're intended for the general public, and we don't have the type of information that is now required by Senate Bill 22. The law says that those orders are invalid. Now, that's the local health district. As Joe mentioned, the Ohio Association of Health Commissioners, we work with the local districts. You know, the Ohio Attorney General's office or the legal staff of the Ohio Department of Health may have more insight than I do on the implications to the state health powers. But as Joe mentioned, the governor vetoed it. He put out a statement. He laid out specific instances where he thought that Senate Bill 22 was a threat to the public health. And, you know, as Joe has mentioned, the veto was overridden by the General Assembly. And so now the new law in relation to state orders, either the governor or the director of the Department of Health or another agency at the state level, there is a oversight and advisory committee by the legislature. And I think that was, you know, pointed out in Jill's analysis as to all of the different elements that Senate Bill 22 affects, whether it's state law or local authorities. Again, I already mentioned this case earlier, but I just thought that it was interesting to see that in adopting Senate Bill 22, the legislators ignored the governor's message in his veto and ignored the wisdom of the Ohio Supreme Court. Senate Bill 22 also allows civil actions against state actors. Normally, anytime anybody sues the state or a state actor in Ohio, it goes to a court of claims. But this law allows it to go to the county jurisdictions. We've seen challenges to local public health orders throughout the state of Ohio. We've seen local courts issue rulings that were overturned by the Court of Appeals because of the jurisdictional issues. Also, just there are several other changes to the state law allowing the Court of Claims where they can go sue this oversight committee. It's just affecting how the state can address public health emergencies. In the governor's veto, he mentioned that he believed that the law was unconstitutional. The question would become about a separation of powers. Unfortunately, the local health districts are creatures of statute. And so they don't have a separation of powers argument. So even if, and I don't have any information as to whether or not the executive branch of the state of Ohio plans to challenge Senate Bill 22 before its effective date, but obviously based upon the governor's veto, they're certainly considering it. And unfortunately for the local health departments, even if they were to challenge it based upon the separation powers or other constitutional issues, the provisions relating to the local health departments are probably going to be intact, subject to further legislative change. So with that, I think we're at a point where we're going to address questions, and I'll stop sharing my screen.
Oops. Thank you, Joe. My video was not working for a second there. All right, so as Joe noted, we are at the portion of today's conversation where we are going to answer questions that have been submitted into the Q&A box. Thank you so much, everyone, for submitting those questions to us during the course of today's webinar presentation. And so now we're just going to go through as many questions as we can in the time that we have left. The intention is that following today's conversation, we're going to be able to hopefully provide some of these answers in a FAQ type of document on that NACCHO University website, included with the slides and the recording of this presentation. So without further ado, the first question that we have through our audience is the following. Is the potential limiting of public health authority incongruous with the 1905 Supreme Court precedent set by the landmark case of Jacobson v. Massachusetts, where the Supreme Court of the United States decision articulated the view that the liberty of individuals must sometimes be subordinate to the common welfare, public health, and would thus be subject to the police powers of the state? So this question is for anyone.
Well, I can say that the experience here is that maybe there is great case law supporting the public health authorities, but certainly at the local level, not always followed. We have seen different courts certainly limiting public health authorities. And so, but I've also seen some great lawyering representing the health departments and citing all of the case law that supports exactly the case and the line of cases that you're talking about.
Excellent. Thank you. So next question, I'm just trying to get to as many questions as possible. Is there a recognized context, otherwise known as location, where a community or communities are using best practices that balance the interests of public health protection along with recognition of representative government to consider factors in addition to public health mitigation efforts and a balanced distribution of responsibility power? It sometimes seems like it's all or nothing, and I am concerned that we will not have the flexibility to act quickly enough to save lives the next time we have a crisis, pandemic or otherwise.
So I don't know if I can name a specific jurisdiction, but I think there are some principles, and in some of the additional resources I cited, you could find some of those principles. You know, and different jurisdictions have passed laws to, for example, increase transparency. If the objection to a public health order is we don't understand the science, what's going on here, what's the reasoning, is this really tailored, you know, do the ends justify the means kind of thing. And so some jurisdictions have adopted laws to increase transparency, to say, if you at the state or local level are going to issue a public health order, lay out your grounds and the criteria for when the order would end. So not a time limited ending for the order, but based on the public health conditions. So that's one example I would cite.
Excellent. Thank you. So next question. How do we properly balance the interest of elected officials to represent their constituencies while at the same time that we want to have unelected specialists protecting public health. Public health officials aren't always trained to be looking at all implications beyond public health.
I think that's a great question. I think that's one thing that we have, again, I sort of mentioned this in my presentation. There is a genuine interest, I think, from our elected officials to know more about what's happening, particularly in an emergency. And I think that's certainly appropriate, and it's our responsibility to share that information. What I find really interesting, though, is when we hear from our state partners, as they provided testimony for Senate Bill 22, there was ongoing dialogue with our elected officials on a very regular basis. And I can't speak for every health department across the state of Ohio, but I know here in Franklin County, we have had ongoing dialogue and updates with all of our state and local elected officials with respect to the public health emergency and the COVID-19 response. So, I think there is always more opportunity to share information, to have that dialogue. And I think those are important conversations that we have to have in public health to make sure that our elected officials are informed, that they do feel like they have a voice, if you will. But certainly, I think the pendulum has really swung way far in the wrong direction in terms of the overreach in terms of legislative involvement. But there is a balance there, and I think that we have to recognize that. And it starts with that open dialogue and communication with our elected officials.
Thank you. All right, next question. Do any of the states that have or are in the process of enacting one of the laws referenced within the report have state boards of health? And if so, have those state boards of health had any impacts on the process?
Jeff, I don't know that any of us know that answer off the top of our head. Certainly many states have a state board of health. And I think what this reflects is what the question reflects, I think goes to, effective public health communications, strategic communications, the influence or lack of influence of public health and how we build those relationships. But also, I think it also raises the question of, just lost my train of thought, did we have a process? Did the legislative session in 2021 in many of these states have enough of a process where different stakeholder groups could provide input? And some states have enacted, early on there were COVID health equity task forces, and some states have enacted legislation to create task forces to have that stakeholder input from a variety of stakeholders, to allow for all of those viewpoints to be heard. And certainly after action reports are another tool that would allow public health to both, assess where there have been gaps and where the response could be stronger the next time around.
Thank you. So we are at 3, but I do want to ask at least one more question for folks on the panel, kind of expand and go to a bigger picture versus what we're discussing here. So this is very open. Any ideas on how to depoliticize public health? So for any of our panelists.
I think that's the big question right now. One of many that I think this webinar has really offered all of us to think about. And I think that's the unfortunate reality, is that public health has become very much politicized. So I don't have a good answer, but I can say that here in Ohio, again, between our local health departments and our public health partners, I think it's really our responsibility to continue to provide the information in a transparent way in terms of how local public health, what our role is, why it's so important that public health continue its work, and when we think about our public health system, that we really move forward to ensure that we are protecting as many residents as possible in whatever public health emergency and day to day, every day. And so that's what we're here to do in public health, is to make sure that we're creating those conditions. And The politics are always going to be there, unfortunately, but it's really our role, I think, to stay focused on what our jobs are day to day to ensure that we're protecting the health of our community.
Thank you. Thank you. So I'm going to jump very quickly back to our slide deck to again note to attendees that the recording for this presentation will be sent to all registered attendees in attendance or not in attendance. We'll send a recording, and the slides and recording will be posted in NACCHO University, and we'll do our best to answer those unanswered questions that have been submitted into the Q&A box, and also list a document with answers to those questions on NACCHO University as well. We include also links to the reference report. You could access it either via NACCHO or the Network for Public Health Law, and Alex was able to send a link related to the report through the chat on today's webinar as well. And so really want to thank everyone in attendance for coming to listen to us discuss this important issue, and really want to especially thank all of our panelists. Thank you so much for being able to share your experience, your expertise, your opinions on this very important public health issue. And with that, thank you so much for joining us today, and we look forward to seeing you soon in our next NACCHO webinar. Thanks again.
Thank you, Jeff.